Good day, dear great surgeons. Let's go for our interesting endocrine chapter and continue our ride through this pillar chapter in the exam. Together we can. Insulin hormone. Insulin hormone is secreted from the pancreas and it's very famous to be anabolic hormone. And by the way, it doesn't increase during stress. Anabolic hormone means a builder, while catabolic hormone means destroyer. So insulin is a positive hormone which help building. It's anabolic from each function. You can notice that it is secreted in response to hyperglycemia. So it will promote the glucose utilization and building the glycogen, which is the storage of the glucose. And it will inhibit any destroying to lipolysis because it's anabolic builder. And of course, it will reduce the muscle protein loss. So, what is the structure of insulin? It's a chain linked by disulfide bridge. And the synthesis of the insulin by proinsulin, which is formed through the rough endoplasmic reticulum in the pancreatic beta cells. This is a great recall idea. It is from the beta cell, the insulin. And then the proinsulin is cleaved to form insulin and C-peptide. The insulin is stored in secretory granules and released in response to calcium. So, what is the half-life of insulin in the circulation? In a normal healthy adult, it will be about less than 30 minutes of work. So, yes, it's a builder anabolic hormone, but it has only 30 minutes to finish its action to build the glycogen, remove the glucose, and inhibit the destruction of the lipids and build up lipid for you. So, thanks for the insulin. We have all a chubby body. We all have fat. Thanks for the insulin. So the insulin is degraded by enzymes in the circulation and typically has a half-life less than 30 minutes, and abnormalities of the clearance of insulin may occur in type 2 diabetes. Take care. Dear great surgeon, take care. Insulin doesn't increase in stress, while growth hormone increases in stress. Thyroid hormone, no change in stress. But take care. The prolactin does increase in stress. This is the trick. I know we talked about it before and you forgot it. The prolactin secretion during stress acts to maintain the homeostasis within the immune system. So take care. Simple topic but very important. The multiple endocrine neoplasia. The men, not women, but the multiple endocrine neoplasia. We are not talking here about the men or the feminist. We are talking about a syndrome. It's inherited as an autosomal dominant disorder, the multiple endocrine neoplasia. We have two types, men type 1 and men type 2. And men type 2 is subdivided in men type 2A and men type 2B. Let's finish from the simple men type 1. It's all about 3B, parathyroid, pituitary, and pancreas. We have a combination of neoplasia. If one came in one person, you have to think that the other two will accompany. So, when you have a patient with parathyroid adenoma, please exclude if he had a pituitary adenoma as well or a pancreatic tumor or not. So, this is men type 1, and this is the importance of the multiple endocrine neoplasia, that when any of the tumors within this syndrome come in any body, you have to exclude the other syndromatic accompanying tumors. So in men type 1, we have 3Bs, the parathyroid adenoma, pituitary adenoma, pancreatic cancer, like the islet cell tumor like Zollinger-Ellison syndrome, and this is the trick in the exam. He will talk about the Zollinger-Ellison, and many forget that Zollinger-Ellison is a pancreatic tumor. I know that Zollinger-Ellison mainly in the duodenum, but remember it can come in the pancreas as well. So, men type 1, parathyroid adenoma, pituitary adenoma, and pancreatic Zollinger-Ellison syndrome. Take care, we are here talking about adenoma. Because the pituitary adenoma can act like prolactinoma or ACTH growth hormone secreting adenoma. The most common pituitary adenoma will be prolactinoma or growth hormone secreting adenoma. So keep them in mind. They are affecting chromosome number 11. So 111, 111. The most common presentation would be hypercalcemia. Regarding men type 2, we have men type 2A and men type 2B. We have pheochromocytoma, medullary carcinoma, and hyperparathyroidism. But in type 2P, we have marfanoid bodies as well as mucosal neuroma, and both men type 2A and P are related to oncogene chromosome number 10. So men type 1, 11. Men type 2, either A or B, will be chromosome number 10. And Zollinger-Ellison, remember, it's a pancreatic tumor, can occur from the pancreas. I know it's mostly in the duodenum, but never forget it with the pancreas because it will be your key for men type 1. I stressed much on men type 1 and type 2 A and B because it's very common to be asked in the exam. So whenever you face a patient with pheochromocytoma, think of medullary carcinoma exclusion or hyperparathyroidism. And if a patient comes to you with hyperparathyroidism, keep the multiple endocrine neoplasia in your mind and exclude the medullary carcinoma and the pheochromocytoma. And even a patient with neurofibromatosis came to you, think of men type 2P. A patient came to you with marfanoid features, think of men type 2P. Exclude them. I don't mean they have to be with each other, but it's an autosomal dominant disorder that can come. So exclude it. Medicine was made to exclude the worst scenario. That's why we have to know the syndromes. Like why God created the medical student to study. Yes, so go for it, tiger. By the way, in the exam regarding Zollinger-Ellison syndrome, he won't mention to you Zollinger-Ellison syndrome and won't mention to you the MEN syndrome and won't mention to you any pancreatic tumor. He will tell you that there is a multiple duodenal ulcers in unusual places, recurrent ulcers, and the patient is already on proton pump inhibitor. This is your key to Zollinger-Ellison syndrome. Keep it in mind. See, medicine is all one thing. You have to apply the knowledge. I know you all know the Zollinger-Ellison. It's most commonly in duodenum than in pancreas. I know now you have focused on the MEN syndrome. But apply this knowledge. How it come to life, how it come to the exam, how can you use it? God be with you. So Zollinger-Ellison syndrome, gastrinoma, pancreatic tumor, MEN type 1, we are all talking about the same thing. Keep them in mind, they are all related. And by the way, the marker for Zollinger-Ellison syndrome will be the gastrin. I'll be happy to have this direct question in the exam. And if it didn't came direct, we are ready. Someone asked me, why in men type 1 you stress that the parathyroid is adenoma and the pituitary is adenoma? Take care. Because in men 2, either A or B, we are talking about hyperparathyroidism. This is will occur due to hyperplasia, not adenoma. Because in men type 1, it will be parathyroid adenoma. In men type 2P or A, it will be hyperplasia. Take care. Dear great surgeon, it's important to know what is the adenoma and what is the hyperplasia and what is the metaplasia and all of those changes. So, we have the adaptation of the cell changes due to stress. Cancer is a stress, so it will cause the cell to go either hypertrophy, hyperplasia, atrophy, or even metaplasia. Hypertrophy is increase in size. Hyperplasia, increase in number. Atrophy is reduction of the size, while metaplasia is changing from one cell type to another cell type. While dysplasia is abnormal development, microscopic abnormal development of the growth. But take care, it's a pre-malignant, it's not malignant. The difference between the dysplasia and neoplasia, that neoplasia is as cancer, a true cancer. Under the microscope, the dysplasia is differentiated from the neoplasia by crossing the line. We have the basement membrane line. If you cross this line, this is neoplasia. If you didn't cross this line, this is dysplasia. So the metaplasia is conversion of one cell from a true cell type to another cell type. It's not dysplasia. Dysplasia is disordered growth. It's not homogeneous growth. It's not another cell type. It's dysplastic, only ridiculous, non-ordered growth. So, for example, let's take an example. The metaplasia. In a cigarette smoker, you have a chronic irritation in the respiratory tract, and you will have the columnar epithelium change to squamous epithelium. So this is a true conversion from columnar epithelium to squamous epithelium. This is squamous metaplasia. And by the way, it's reversible in most times, unlike the dysplasia. The atrophy occur in real life, like if you immobilize a limb for a long time, the muscle will go atrophy. Hyperplasia occur like hormone-driven increased estrogen level, which give rise to endometrial hyperplasia in the uterus, for example. Or even physiological can occur in hyperplasia with the liver. Thanks for the hyperplasia, the liver transplantation can occur. This is due to hyperplasia. Liver cell proliferate after partial hepatectomy for the donor and for the recipient. Both go through hyperplasia. So thanks God for hyperplasia. It's a good thing. It's not always a cancer-driven hyperplasia endometrium in the uterus. It can be a physiological thing. So the metaplasia is always pathological. The dysplasia is all pathological, while the atrophy, hyperplasia, and hypertrophy, it can be either physiological or pathological. For example, the hypertrophy. We agreed that hypertrophy means increase in size. The pathological example for hypertrophy will be with the hypertension, there is increased workload in the left ventricle, for example. So this will have a big heart. It's not a good thing to have a big heart. Have it as a metaphor, but for real, if you have a heart who is enlarged, it's not a good thing at all. It can cause a heart failure. Left ventricular hypertrophy can cause heart failure and can cause pulmonary hypertension. So keep it in mind. It's not always good to have big organs. Be a balance. This is pathological thing. While in hypertrophy, physiological changes like in pregnancy, hormonal induced uterine smooth muscle go hypertrophy. If you go to gym, you will have hypertrophy for your muscle and build up your six packs. So keep it in mind. And of course, neoplasia is always pathological. There is no physiological neoplasm, by the way. So the most common question in the exam will be tricking you regarding the metaplasia, that it's always pathological but it's reversible, while the dysplasia is differentiated from the neoplasm by the basement membrane. Keep it in mind. A very good question to ask me: is dysplasia reversible or not? Sharp answer: if it's mild to moderate dysplasia, mild to moderate change in growth, it will be always reversible if you remove the stimulus and the causative stimuli. However, the severe dysplasia becomes irreversible and might be considered pre-malignant lesion due to the ability to progress to carcinoma. So, we now all agree that men too have pheochromocytoma with medullary carcinoma and parathyroid hyperplasia. So regarding the pheochromocytoma and the rule of 10, We all know that it's a neuroendocrine tumor of chromaffin cell of the adrenal medulla, and the adrenal medulla secreting the adrenaline and noradrenaline. That's why the patient will be manifesting with hypertension that is resistant. So hypertension and hyperglycemia are often found, and 10% of the cases of the pheochromocytoma will be bilateral, so it's mostly unilateral. 10% will be in children, so it's mostly in adult, and 10% will be malignant, so it mostly will be benign, and 10% will be hypertensive. No, it's 90% will be hypertensive. Take care. The rule of 10 in pheochromocytoma is a little bit confusing. Keep in mind that the most cases of pheochromocytoma will be unilateral in adult and mostly benign and will be hypertensive. Take care, because I know that the 10% rule in pheochromocytoma, I don't know the scientist who brought it up. I prefer to make it the 90% pheochromocytoma theory than the 10%, because the 10% makes it seem like not logic at all. He is telling you 10% will not be hypertensive. Take care. We are talking about that most of the cases, 90% of the cases will be resistant hypertensive, and this is the key in the exam. So how come I remember that 10% will not be hypertensive? This is confusing. He wasn't drinking coffee when he was writing this 10 theory. So keep in mind that 10% will be bilateral. That means that it mostly will be unilateral. 10% will be not hypertensive, so it mostly will be hypertensive. Take care. It will be diagnosed by CT and MRI scanning along with the urinary analysis of vinyl mandelic acid, as well as the blood testing for plasma metanephrine levels. To be treated, the patient requires medical therapy first, and an irreversible alpha adrenoreceptor blocker should be given. So the alpha blocker will be given as an initiative medical therapy in pheochromocytoma, although minority prefer reversible blockade, but labetalol may be co-administered for cardiac chronotropic control. And as well, the isolated beta blocker should be not considered as it will lead to unopposed alpha activity. So again, give the alpha adrenoreceptor blocker, alpha blocker. The patients are often volume depleted and will often require moderate volume of intravenous normal saline preoperatively. Once the patient is optimized, the pheochromocytoma should be removed. And by the way, the pheochromocytoma is not incidentaloma. It's not accidental discovery of its incidental adrenal lesion. The adrenal lesion may be identified on CT scanning performed for any other reason if the size is less than 3 or homogeneous texture and lipid-rich tissue and thin wall to the lesion. This is most probably not pheochromocytoma. Go test the patient for the metanephrine and urinary vinyl mandelic acid and test his blood pressure. He is not pheochromocytoma. It's incidentaloma, incidental adrenal lesion. No fear from it and no surgical intervention required, unlike the pheochromocytoma which require removal. Please don't mix up the tumor markers. We have the urinary vinyl mandelic acid as a measurement for the pheochromocytoma, which might be associated with the MEN2. Regarding the other tumor marker, like the urinary 5-hydroxyindoleacetic acid, the 5-HIA, it's for the carcinoid tumor. So the carcinoid tumor might come in the appendix. So we all do appendectomy in our daily routine as a general surgeon, but take care, it might be carcinoid tumor. That's why it's preferable to have an eye of a hawk during your surgery, and after the surgery send every appendix for histopathology. It might be carcinoid tumor. And chill out. If it's in the tip of the appendix and less than 2 centimeters, there is no fear. Most probably it's not carcinoid. And even if it was carcinoid, the only solution for the tip carcinoid of the appendix, if it's less than 2 centimeters, will be only appendectomy. The trick will be if the carcinoid changes more than 2 centimeters or the carcinoid changes at the base of the appendix, then you will have to do a formal right hemicolectomy. So don't confuse the tumor markers and don't fear during your surgery from the carcinoid tumor, but medicine is incidence and you have to have a eye of a hawk. I wonder no one asked me if we have three tumors, the medullary carcinoma, hyperparathyroidism, as well as the pheochromocytoma. Which to deal with first? Should I remove the medullary carcinoma first or the pheochromocytoma first in the MEN2 syndrome? Of course, go for the pheochromocytoma, or the patient will go for adrenal insufficiency. This patient will go for adrenal storm because he has a gland is devastating and secreting all over adrenaline and noradrenaline. Please remove it. Otherwise, your patient will die from stress. He is running in place from the pheochromocytoma by the effect of the adrenaline. Give this patient a break and remove the pheochromocytoma, then go for it and remove the medullary carcinoma. And by the way, he can die early from all of this. So save this patient life and control the pheochromocytoma first, then go and manage all the patient other problems if he's still alive. Yeah. This is the core of surgery, to know and validate and evaluate the importance of the knowledge. By the way, surgeons did know this knowledge by continuous errors and corrections. They tended before to correct the medullary carcinoma and the patient died from the pheochromocytoma. That's why you have to save the patient by managing the pheochromocytoma and not do like the previous surgeons done and go for the medullary carcinoma. It's not about the cosmesis in the neck. It's all about what is the core of the patient. So deal with the core of the problem, not the superficial problem. Superficial problem might be the medullary carcinoma. It's agonizing, not well looking in the face and the neck. No, it's all about what is in deep in the adrenals. Go solve the problem from the adrenals and you will solve the whole syndrome in steps in correct way. There is a funny thing regarding the parathyroid neoplasm. Did you know that the parathyroid carcinoma accounts only for 5% of the tumors? It's good news, right? But take care. 85% of the cases of primary hyperparathyroidism are due to a single adenoma. And by the way, this will be associated with the MEN syndrome. So if he didn't die from a true parathyroid carcinoma, he will die from the MEN syndrome associated tumors. Haha. He is a lucky person to die from the parathyroid. Those four golden yellow glands will kill him anyway. 5% carcinoma, 85% from the adenoma associated with the MEN syndrome.